Our next view is the apical view. Apical views, we have already said that we have 4 apical views. Here is the apical 4-chamber view. 4-chamber because we can see here 4 chambers. Here is the left ventricle, left atrium, right atrium, right ventricle. Here is the interventricular septum. Here is the apex of the left ventricle. Here is the lateral wall. Here is the tricuspid valve. Here is the free wall of the right ventricle. Here we can see the mitral valve. This leaflet, the long one. The medial one is the anterior leaflet. The short one is the posterior leaflet. Here on the right side, we can see the septal leaflet of tricuspid valve, and the other leaflet is most probably the anterior tricuspid leaflet. How we got this view? I will go back to the same slide. Here are the apical views. Apical 4-chamber. The position of the marker should be directed toward 2 to 4 o'clock. The same thing for the 5-chamber view. I will tell in short the difference between 4 and 5-chamber view. For the apical 2-chamber, we have to rotate the probe so that the marker should be pointing to 12 o'clock. In the apical 3-chamber view, the marker should be further rotated, or the probe should be further rotated so that the marker is pointing to 10 to 11 o'clock. We will go back to the same video. I will repeat all the views together. At first is the parasternal long axis view, probe pointing toward 9 to 11 o'clock, tilt up, right ventricular inflow, then tilt down, right ventricular outflow. One more time, parasternal in the middle, tilt up, right ventricular inflow, tilt down, right ventricular outflow, then rotation to get the parasternal short axis, marker pointing toward 12 o'clock, almost 12. Then with tilting, further tilting towards the right shoulder, you can get all the parasternal short axis views. Then what we wanted to see is the apical view. The marker should be pointing toward 2 to 4 o'clock, apical 4, then 12 o'clock, apical 2, further rotation. We can get around 10 o'clock the apical 3-chamber view. One more time, 2 to 4 o'clock, apical 4, apical 2, 12 o'clock, 10 o'clock, apical 3-chamber view. We have to notice in the apical 4-chamber view, the ventricles are normally longer than the atrium. In other words, the atria are smaller than the ventricles. When you see that the atria are bigger than the ventricle, it's abnormal. There is abnormality. We have to find why are the atria larger than the ventricles, but normally the ventricles are larger than the atria. And the left ventricle is always normally bigger than the right ventricle. It is also important to notice left ventricle is bigger than the right ventricle, and the ventricles are bigger than the atria. An important tip here, the left ventricle, you can see that the left ventricle is in the middle of the screen. Sometimes when we want to get apical for chamber view, the ventricle is oblique, as we can't get the view so that the left ventricle in the center of the screen. We can see either that the ventricle oblique on the right side or on the left side. Here is that what I mean. We should get the ventricle so that the ventricle should be in the middle of the screen. Sometimes the ventricle looks like that or looks like that. It is oblique. How we can correct it? When we have a left ventricle that looks like that, it lies obliquely, you have to do that. When the ventricle looks like that, you have to move the probe further downward and lateral. When you move the probe in this direction, the apex will go in that direction. One more time, when the ventricle is oblique toward the right side of the screen, you have to move your probe downward, one space, downward and laterally in the anterior axillary line, for example, downward and lateral, then your oblique image will look like that. In the same manner, when the ventricle is oblique but to the left side, you have to move your probe medially and downward. Then the ventricle will move in the center of the screen. It is a very important tip for echo beginners. From the apical view, we see also here at the bottom of the screen this black line or almost black channel. This is one of the pulmonary veins, most probably the right upper pulmonary vein. It is an important structure. We can discuss this perhaps in next lectures. About pulmonary veins are important structures. We can obtain data from pulmonary veins to help to quantify diastolic function, help to quantify the severity of mitral valve regurgitation. We can obtain this from an apical four-chamber view. Apical four-chamber, we place here the color Doppler, and then we place a pulsed wave. We can get a wave like this. Here is two waves, systolic wave, S wave, and diastolic wave. The importance of pulmonary vein flow can be, and its uses I will discuss perhaps in next lectures about it's beyond the spectrum of our presentation. I have said, how can you get a wave like this, a pulmonary vein flow? From the apical four-chamber view, then you place color to see the flow, then pulsed wave, then you will get something like that. S wave systolic wave and diastolic wave, S wave and D wave. From the apical 4-chamber view, all you have to do is to tilt the probe slightly downward. You will get the apical 4-chamber view, the apical 5-chamber view, excuse me. It is not a 5-chamber view because the aorta is not a chamber, but we call it an apical 4-chamber view. Apical 4-chamber, we see here the right ventricle, the left ventricle, here left atrium, the aorta. Also, we get 4-chamber view, we tilt the probe slightly downward, we get an apical 5-chamber view. Then we go back to 4-chamber view, then rotation. We will rotate the probe so that the pointer will be directed towards 12 o'clock. We will get the apical 2-chamber view. 2-chamber, here we have the left ventricle, left atrium, and here we have the anterior wall of the left ventricle, and here is the inferior wall. Anterior wall is here and inferior wall is here. Here is the anterior wall, here is the inferior wall, and here is the apex. Here is the left atrium. With further rotation, the probe marker should be toward 10 o'clock. As we have said, we get the apical 3-chamber view. Here is the septum of the left ventricle. Here is the posterior wall of the left ventricle. Here we have the mitral valve, anterior mitral leaflet, posterior mitral leaflet, left atrium. Here is the aorta, mid-aortic valve. Here we see a part of the descending aorta. The structure is always the descending aorta. So, in the apical 4-chamber, we are seeing the heart from this side. We will see both ventricles and both atria with slight downward angulation. We can see the aortic valve. In 2-chamber, we are cutting only along the left ventricle. With further rotation, we can cut through the aorta in the apical 3-chamber view. Our next view is the subcostal view. In the subcostal view, we see the heart from the diaphragmatic surface. We can see here part of the interventricular septum, right ventricle. Here is part of the left ventricle, left atrium, mitral valve. Here is the tricuspid valve. This view is very important when the patient has a pericardial effusion. You should see here the effusion. Of course, our patient is normal. We don't see here abnormal findings. Another important thing is the subcostal view. Here is the interatrial septum. We can place here a color Doppler. It is very important view to investigate the interatrial septum to look for interatrial septal defect, ASD, or patent foramen ovale. The second important thing about the subcostal view is to examine the IVC, the vena cava inferior or inferior vena cava. The diameter of inferior vena cava gives us important information about the central venous pressure. As the inferior vena cava, when the inferior vena cava is dilated, it means that the patient has hypervolemia or high intracardiac pressure that has many therapeutic consequences. When the inferior vena cava is collapsed, that means perhaps the patient is dehydrated. I'm going to talk about the inferior vena cava in a separate lecture. But for now, it is important to know that the subcostal view is very important and should be done in all echo examination to investigate the inferior vena cava. But how we get the subcostal view, I will go back to the main video. We will see all views together with the suprasternal view, and I will go back to see our last view. Once more time, our sternal long axis view, marker pointing toward 10 o'clock, then tilt up, right ventricular inflow, then tilt down, right ventricular outflow. One more time, tilt up, right ventricular inflow, tilt down, right ventricular outflow, rotation toward 12 o'clock to get the parasternal short axis views with further tilting, level of mitral valve, level of papillary muscles, level of left ventricular apex, all with just tilting. Here is the apical 4-chamber view, almost just below the nipple, rotation of the markers towards 12 o'clock 2-chamber view, further rotation to get the 3-chamber view, almost 10 o'clock. One more time, apical 4, apical 2, or 12 o'clock, apical 3, all with rotation. Here is our view, the subcostal view. The marker should be pointing toward 4 o'clock almost. The patient should take a deep breath and hold it, then we'll see our view. With slight rotation from 4 o'clock toward 1 o'clock, you can see the inferior vena cava. Here, subcostal, here is inferior vena cava. Slight rotation from 4 o'clock toward 1 o'clock. Our last view that we will see is the suprasternal view. Suprasternal view, marker should be pointing toward 1 o'clock, and we will see the aortic arch, descending aorta, part of the descending thoracic aorta and part of the ascending aorta, and from the aortic arch, the great vessels are originating from the aortic arch. Back to our subcostal view, we have known how to get it. Our next view will be the suprasternal view. Suprasternal view, we have seen how to get it. We will get view like that, aortic arch, part of the descending aorta. Here we can see the left subclavian, here a second artery, most probably the carotid, common carotid. This view is important and should be done as a standard echo view. We can For example, important information we can obtain from this view. Here I have placed color Doppler on the proximal part of the descending aorta. And here I have placed a pulsed wave. With the help of color Doppler and pulsed wave, we can see if the patient has a significant aortic regurgitation. Normally, the flow in the descending aorta from proximal to distal in one direction. Normally we will see that wave. If we see a second wave here, this means that the patient has a retrograde flow. Retrograde flow in the descending aorta is an important sign of significant aortic regurgitation. Second important thing we can obtain from here, if the patient has an aortic dissection, we can see sometimes here a dissection flap. We can see also when a patient has a patent ductus arteriosus. This can be easily seen from this view. If the patient has coarctation of the aorta, can be seen from this view. And these important things we can discuss it in further lectures.